Hey everyone, welcome to today's Explainer. We're stepping right up to the whiteboard today to map out three distinct pediatric structural conditions, traveling from the top of the neck all the way down to the feet. We're going to be looking at congenital torticollis, clubfoot, and developmental dysplasia of the hip, or DDH. These are structural and developmental issues that require super sharp nursing assessments and very specific timely interventions to make sure these young patients develop properly.
To keep our clinical wires completely untangled, here's our agenda for today. 1. Torticollis, the twisted neck. 2. Clubfoot and a Ponseti method. 3. DDH, risks and diagnostics. 4. DDH, treatment and harness. And 5. Shared orthotic device care. Let's get right into it. Section 1. Torticollis, the twisted neck pit.
So, torticollis. It's essentially an abnormal neck position, and it's most often caused by the contraction, shortening, or just general dysfunction of the sternocleidomastoid muscle. Because of this, you're going to see the infant consistently turning or tilting their head to one preferred side. The good news here is that with consistent early treatment, this can usually be resolved in about 6 months. Treatment is heavily focused on physical therapy and gentle prescribed stretching. Sometimes they'll use a tubular neck orthosis, which is basically a little collar that infants wear to help straighten out their neck position. We also teach parents to position the infant in ways that encourage head turning toward the non-preferred side.
But real quick, I want to draw a hard mental line here and highlight a critical safety alert. If you see this acute neck tilt, but it's accompanied by a fever, vomiting, a severe headache, neurological changes, or signs of trauma, that requires immediate provider evaluation, no exceptions. In these instances, you absolutely do not just manage this with routine home stretching. Why? Because those symptoms are massive red flags pointing to a potential infectious or neurologic process rather than a simple congenital muscular torticollis. Always assess the whole clinical picture.
All right, moving on to Section 2, Clubfoot and the Ponseti method. Now we're jumping from the neck all the way down to the feet. Clubfoot is this complex deformity where the foot is twisted inward and downward. Now, treatment has to start super early, like within the first 2 weeks to a month of life. This early intervention is totally critical because the infant's bones, joints, and soft tissues are incredibly responsive to gradual correction at this stage. The absolute gold standard treatment here is the Ponseti method, and we map it out in 3 broad steps. Step 1 involves gentle manipulation and stretching of the foot by the physician, followed immediately by serial long leg casting. These casts are swapped out weekly for about 5 to 8 weeks, with fresh stretching happening right before each new cast goes on. Step 2 is heel cord or Achilles tenotomy. That's a minor procedure to release the tight tendon, and it's usually done once they've hit maximum correction from the casting. This is followed by about 3 more weeks of casting. And finally, step 3 is the long-term bracing phase.
Now listen up, because this is where people literally always get tripped up on exams. We've got to clearly distinguish between these 2 phases. Casting actively corrects the deformity. It's gradually stretching and repositioning that soft tissue and bone. Bracing, on the other hand, which uses an abduction brace that looks kind of like 2 shoes connected by a bar, does not correct anything further. The brace just maintains the correction that the casting already did, and it stops the foot from relapsing back into its original twisted position. This bracing phase is a long haul, too. It can last for 4 to 5 years, worn mostly at nighttime. So remember, casting equals correction, bracing equals maintenance.
Section 3. DDH, Risks and Diagnostics.
Moving right up to the hips, we hit developmental dysplasia of the hip, or DDH. This is an abnormal development where the femoral head just doesn't fit properly into the acetabulum. So the crucial point here is knowing who's actually at risk. You must be able to recognize this classic cluster of risk factors right off the bat: female sex, firstborn status, breech intrauterine position, and family history. If you see this specific combination, your index of suspicion for DDH should be extremely high. Also take special note of an environmental risk factor: improper tight swaddling. Wrapping an infant's legs tightly in extension and adduction directly increases the risk of DDH. So for health promotion, we've got to teach parents hip-healthy swaddling. You have to allow the hips and knees plenty of room to flex and move around naturally. To actually diagnose DDH in infants, providers use 2 very specific physical exam techniques. Let's memorize these heavily tested diagnostics with a super simple whiteboard cue. The Barlow maneuver attempts to dislocate an unstable hip. Think, Barlow pushes back and out. The Ortolani maneuver attempts to reduce a dislocated hip. Think, Ortolani opens and reduces. These are classic point of confusion pairs on exams, guys. Just remember, Barlow dislocates, Ortolani reduces.
But while we're on the topic of these specific hip maneuvers, let's pause for a really vital clinical judgment question. Think about your scope of practice. Who is actually performing these distinct pushing and opening maneuvers on the tiny infant?
The answer? The provider, not the nurse. As a nurse, you never perform the actual Barlow or Ortolani test yourself. Your nursing assessment role is to look for asymmetrical or unequal posterior gluteal skin folds, limited hip abduction, or maybe noticing that one leg appears shorter than the other. If you see those visual or mobility cues, you report them immediately so the qualified provider can come in and perform the specific diagnostic maneuvers.
Which brings us to Section 4, DDH, Treatment and Harness.
All right, so we've diagnosed DDH. What's next? For newborns up to about 6 months old, the go-to primary non-invasive treatment is the Pavlik harness. It's an abduction orthosis worn almost continuously. Now, you might actually encounter some textbook phrasing stating that the harness prevents hip flexion and adduction. However, clinically speaking, we know the harness is actually designed to maintain the hip in a flexed and abducted position to promote stable joint development. Because this specific textbook wording totally contradicts the known clinical reality of how the harness functions, you shouldn't just memorize it blindly. You've got to use your critical thinking here and verify this exact expected phrasing with your instructor for your exams. It's honestly a perfect example of why we have to constantly analyze our source materials.
It's also absolutely crucial to remember that DDH treatment is strictly dictated by age. Once a kiddo hits that 6-month mark, the Pavlik harness is completely off the table. The infant is simply too big, and the hip just becomes way less responsive to this harness method. If you have a parent asking why their 8-month-old isn't getting a harness, you need to clearly explain this age-based rationale. For children over 6 months, they'll transition to a closed reduction under anesthesia, which is then followed by a hip spica cast to hold the joint firmly in place.
And finally, Section 5, Shared Orthotic Device Care.
Let's synthesize all this. We've got 3 different devices for 3 different body areas, and putting them side by side gives you a really unified clinical framework. For the neck, we have the tubular orthosis for Torticollis, helping to straighten out that neck position. For the feet and lower legs, we have the abduction brace, the shoes and bar setup, used after Ponseti casting for Clubfoot to maintain that hard-earned correction. And for the hips, we have the Pavlik harness, used for DDH, maintaining the hips in that therapeutic position for proper joint development.
Because here's the secret. Regardless of whether you're looking at a neck tube, Clubfoot boots, or a hip harness, your shared nursing priorities remain exactly the same. First up, frequent neurovascular checks. These are non-negotiable. You absolutely must assess distal toes or fingers for color, warmth, movement, and capillary refill. Second, frequent skin integrity checks are essential. Get in there and look under the straps, especially down in the diaper area for a harness or spica cast, and use interventions like cotton layers or cornstarch exactly as recommended to prevent chafing. Third, never ever adjust the prescribed straps without a direct provider order. The provider sets the specific therapeutic tension. If you adjust it, you could literally undo the medical intervention. And finally, parents should be taught to use sponge bathing. It's the best way to protect both these orthotic devices and any cast from getting wet and compromised.
I'm going to leave you with a final clinical puzzle to test out your new synthesis skills. Imagine an 8-month-old infant gets diagnosed with DDH today. Why won't a Pavlik harness work? And what specific cast care principles are their family going to need to learn? Think about the age limits we just discussed, the transition to spica casting, and those universal skin and neurovascular care guidelines we just outlined. Connect those dots, and you'll have totally mastered this material. Thanks so much for joining me on this explainer, and keep that focused momentum going.